Going to talk about metabolic modulation of reproductive success, the role of semaglutide in advanced age fertility. Dr. Aradhana Gupta, she is director of Aradhana Test Tube Baby Center, Bhopal, and West Zone coordinator of Fertility and Aging Committee of Indian Menopause Society, managing committee member of MPSR, executive member box, and 29 years
short
experience.
introduction. We are running short of time actually.
Okay. And various awards and publications.
The most important from the point of IMS that I am with Madam Vanita Medgood as a West Zone coordinator of Fertility Committee of IMS. Ma'am is a chairman of that committee. So it's all guidance of Vanita ma'am. So before I delve into this little out of the box topic, because now there is a lot of hue and cry about the anti-obesity medicines, and the clinical aspect is should be right or not this medicine. But with the approval of the DGCI, though we can now write this medicine, but with a pinch of salt. And before writing these prescriptions, you should know a lot about them. Morning somebody was asking what is Munjaro. So people have little less knowledge about it. And now we are here for the advanced age infertility, and why I am taking this topic. The content related are the impact of obesity in women's health, especially in the advanced age, menstrual irregularity, PCO, fertility management guidelines, and practical know-how for the clinicians. So in advanced age infertility, we all know that there is a decreasing ovarian reserve, and beside that there is a resistant obesity in both the partners. And this resistant obesity is also related with the faster decline in the ovarian reserve. There is an increased free testosterone index in male, and there is an associated comorbidity like diabetes and hypertension to reduce time to pregnancy. To decrease pregnancy complication, we have to make them little thinner, and epigenetic factors during pregnancy due to insulin resistance, they enter into the fetus also. So globally, women obesity rates are increasing. We all know previously we used to see thinner patient, and now almost every second, third patient is a obese patient or overweight. So it is expected that globally 1 in 5 women will be living with the obesity by 2030. So 2030 is not very far, and this is you can see that in 2020 658 million were obese, and now in 2030 we are expecting 882. So it's a very fast, like a fast food. So fast food is associated with this. So now how it is connected with the obesity in midlife. We all know there is a estrogen decline, and that increases the visceral adiposity, and it also accelerated metabolic dysfunction. There is a rising insulin resistance with the age, and sarcopenic obesity phenotype you can see in this age group, and there is a increased inflammatory burden, and these all are associated with the another cause of the infertility beside the aging phenomena. So what are the impact of obesity in women health? There are almost from the tip to toe, there are almost every organ is affected by the obesity, because it's a generalized metabolic disorder, and now obesity is taken as the disease by WHO. So we are focusing now here on the infertility issue, and we all know it is an endocrine disruptor. Beside PCO and pregnancy complications, menopause is also affected by the obesity, and there is a menstrual irregularity in both the peaks of the fertility. Then there are some beneficial effect of body weight reduction in women, and we all know, because we always ask our patient that you should cut down your weight, you change your lifestyle, you look for your diet. And why we are saying this? Because obesity is closely associated with the reduced fertility in women, and almost every reproductive part of the system affected by the obesity. Like if you go for the follicle, so will be the increased follicular apoptosis, there are early follicular atresia, and the uterus stromal decellularization will decrease, endometrial receptivity is decreased, at the level of your pituitary, again there are a lot of changes, and in the fat cell there are increased leptin, TNF alpha, interleukin 6, they are increasing, and this way they increase the insulin resistance and hyperinsulinemia, and thus cause infertility. Also in liver, this causes decreased synthesis of serum hormone binding globulin, and that causes the free fertility hormones in the blood, and that free estrogen will convert into the androgen in the peripheral fat cell, and that again causes the infertility. What about in male? It's not only related with the female. You can't blame only female partner. In male, again, there is a sperm production decreases in obese men, and we all know about the free testosterone index, because in the obese men there's a little higher side of the estrogen that affect the testosterone estrogen ratio, which is known as the free testosterone index, and that reduce the sperm production. For that we give the aromatase inhibitor. We know this thing. So these are like some guidelines by the ASRM, by the American Society in Metabolic and Bariatric Surgery and British Fertility Society, and they recommend pre-conceptual counseling to address the reproductive and maternal fetal consequences of obesity, and as well as they say like even 5 to 10% weight reduction can restore your fertility. And we always ask our PCO patient to cut down this. And mind it, this PCO is not only for the adolescent and for the reproductive. Even at the higher age group, if you see the antral follicle count, it looks like normal, but for that age, it is higher. That means she is a PCO. Right. So now come to the obesity and infertility. BMI, if it is more than 30 kilogram per meter square, it decrease in natural conception by 4% per BMI change. So it's a significant cause of infertility. And causative mechanism we have already talked about. Role of leptin is there, and immunological factors are also there. So now, what are the benefits of weight loss in menstrual irregularity? Again, it's just like a PCO thing. We all know that the androgen level decrease by reducing the weight, and that will make the cycle regular. So hyperandrogenism is a very defining feature of the PCO, and that is the most important part of the PCO. If we take for the phenotype, so first three phenotype, they include the hyperandrogenism, and fourth one is not taken as a very important factor. So now come to the effect of obesity on the treatment of female infertility. When we treat, for the infertility, they need higher doses of hormones, and sometimes they don't respond to the treatment. Even the oocyte and embryo quality in women in IVF also reduce because of this. So it doesn't, it's not only affect the fertility, it affects the later on, in the pregnancy there are a lot of issues. Then at the time of birth, there are even birth dystocia because of this insulin resistance. There are large size babies, premature delivery can happen. And in the offspring, again they are at a higher risk of stillbirth, obesity, asthma and diabetes. So now come to the anti-obesity drug for which I am talking, and my time has already been finished, so I'll making it fast. There are this was the medicine available are the liraglutide, then this naltrexone, orlistat. I think we are using orlistat since I think more than 10 years, and then phentermine, and then semaglutide. But here you see the government DGCI, they have approved only orlistat and semaglutide. Okay, so these are the two medicines, but now there is a new drug in the market, Mounjaro, jiski maine abhi bola, that is agonist to both the receptor, GLP receptor as well as GIP receptor. Okay, semaglutide is only GLP receptor agonist. Okay, so how it acts? Number one, it is also included in this ISAR consensus algorithm 2024. They recommend that beside orlistat, semaglutide is also can be used to reduce the obesity, which is otherwise cannot be reduced by the patient. So, how it acts, semaglutide acts at the two level. Number is the brain, at the level of brain, and another is the at the level of stomach or gastric emptying. So, it slows the gastric emptying, and that is why patient feels like fullness. And another is the, it affects the, it has the action on the brain. So, it stimulates the satiety center, and again they feel that I am not hungry. But there are some side effects also. So, you should understand that these are the different area where these GLP receptors are present, and because of delayed gastric emptying, it causes vomiting or nausea. There's a huge nausea and vomiting thing in some of the patients who are very much sensitive to it. So, it works for both type 2 diabetes as well as obesity, but it can be given for even for the obesity purpose alone also. So, it is approved for this purpose also. And these are the different trials, and we have to start with the lowest doses 0.25 milligram, and weekly we increase the dose, monthly we increase the dose. So, we give it a weekly, it's a weekly regime, and increase the dose every month. And this is how you reach to the 2.4 milligram, and that is the final dose, and that causes even more than 20% weight reduction in more than 1 out of 3 patients. And there is a sustained weight loss over 4 years. But once you stop it, the weight gain may come again, and for that you have to maintain the therapy with these patients, and you have to bring down to a particular level where you want to make them pregnant, and then you can start your fertility treatment. Okay, so this is how you can use in your infertility patients. So these are the guidelines I have already told you, and it is also present in the PCOS guideline. ISAR has also, Dr. Nandita Palshetkar and Dr. Pai, who are my mentor, they have presented this paper, and there is the article is optimizing obesity management for women in Indian obstetric and gynae setting, and it is approved. Mind it, when the what are the indication, if the patient BMI is more than 27 or 27 with one factor which is a comorbidity, then you start it, or without comorbidity, even if the BMI is 30, then you can start it. Okay, so be careful. No? It should not be given for the like 25 or borderline kind of the people. So Wegovy is a brand name for the semaglutide, and Mounjaro is for the GIP-1 and GLP-1 agonist. So there is special consideration. You always add one contraceptive, because right now there is no study which say that you can give in the pregnancy. So be careful. But if she get pregnant by chance, then there is there is no role of MTP. You can ask the patient, she can continue, because as such they are not teratogenic drug. But because we don't have any human study or long-term study, so we can't allow them to make pregnant. But if by chance they become pregnant naturally, then she can continue the pregnancy. Okay, and in the renal patient, in the patient who is having pancreatitis or history of pancreatitis, the word of caution is there. So in such people, you need to be careful about. So thank you for giving me a reason to scratch my brain, because this topic is also new for me. So I have heard a lot of talk related with this. So I thought I should take it to the gynecologist, because till now only the endocrinologists they are talking about it. So I thought the gynecologist should also start, and this very simple thing I have given to so many patients. There's liraglutide is oral one, and these two are the Mounjaro and Wegovy. These are so that is come as a Rybelsus. Oral is Rybelsus, but for the weight reduction it's not a good drug, and that is also not approved. So you can't prescribe. And if you want to prescribe, just write that on the patient demand. Then you can prescribe.
I just want to highlight few things for this drug. this, when you take this drug, you have to cut down your diet also. If you do not cut down your diet, it will not reduce your weight.
There is one
First.
more thing.
And
Yes.
secondly, to
Exercise.
a patient of gallstone, it is contraindicated because it can turn into gallbladder cancer. And to many patients, it can cause pancreatic cancer also. So, pancreatic also, and gallstone is a contraindication till is written in the literature. And secondly, when you stop it, there is bounce back, the weight bounce back. So it is recommended that when you start this drug, you take it as an adjuvant and you change your lifestyle to such an extent and diet to such an extent that when you stop the drug, you can continue to maintain the weight and there is no rebounds of the drug.
So
But sometimes they say, nowadays they are saying, endocrinologists are saying that this drug has to be continued throughout your life.
So basically, it causes sarcopenia, in fact, right? Ma'am, the weight reduction on the both side, your fat as well as your muscle. So it causes sarcopenia also. So be careful. You always tell your patient the exercise, especially the resistance exercise, are must with this medicine. But nowadays, there's one more, I don't think there's a time, one more, compound has come up. There is a lot of studies about this in US that causes the, self-exercise, kind of these muscles. There is a chemical which stimulate the muscle for the growth. And they have the chemical which, or I would say a medicine, which will cause this, growth relating thing as a agonist way. So if they are combining this anti-obesity drug with that particular molecule, and now this combination is something like आप घर में बैठे हो, you don't need to exercise, you don't need to do anything, and still your muscle will be maintained and your weight will be reduced. So people have become so lazy, they want everything.
Look, there is a robotic pregnancy also, surrogate. She will carry your pregnancy.
I read about this molecule. I thought that people are so lazy. They have found, the alternative for this purpose also. Ki, okay, I will not have sarcopenia. Just stimulate my muscle by the medicine.
Rebound तो होनी है फिर जैसे stop करोगे.